Good morning, my dear student. Today we are going to discuss about anti-arrhythmic drugs. Okay, what is anti-arrhythmic drugs? Certain disease and the effect of some drugs are usually responsible for affecting the rhythm and the normal heart rate. This cardiac arrhythmia may be caused from the disorder in pacemaker function of the sinoatrial node, thereby resulting in the tachycardia, bradycardia, cardiac arrest, AF, and atrial fibrillation and ventricular fibrillation. Hence, the antiarrhythmic agents are used or is termed as anti-dysarrhythmic drugs or anti-fibrillatory drugs. Okay, so antiarrhythmic drugs may be defined as drug that capable to reverting any irregular cardiac rhythm or rate to normal. In other words, an arrhythmic situation is the wherein either initiation or the propagation of heart rate stimulation is found to be invariably abnormal. Okay, at this junction, it is the worthwhile to have a little depth knowledge in regarding normal sinus rhythm and aspects of electrocardiogram. Okay. Okay, in this one, we are going to discuss about, in this chapters, we are discussing introduction, classification, and drug used antiarrhythmic agent, mechanism of action, rhythm, structures and synthesis, and the adverse drug reactions and the uses. Okay, so now we can see the basic introduction regarding this one. Arrhythmia may be occur due to the abnormalities in the normal rhythm of heart rate, causing irregularities in the heart rate. Synovial node present in the right artery as well as act as the main pacemaker which initiate the impulses. Any abnormality in the rhythm of heart may be hinder the formation as well as conduction of impulse together the heart. The abnormality is termed as antiarrhythmic drugs. Antiarrhythmia. So arrhythmia, right? So we already mainly it is it is synovial node. All the electrocardiogram. Already you studied in the physiology electrocardiogram. So this is the normal heart, synovial node, normal electric pathways, and this one. So what about the arterial fibrillation? So the arterial fibrillation impulses will be there in the thing. Then the chotic signals, rapid ventricular impulses. So these are the ventricular, this one. Now we can see the causes of arrhythmia. So arrhythmia may be precipitated due to the following reasons. Maybe underlying heart disease, thyroid disease, that means especially hyperthyroidism, hypertension, heart rate problems. Okay. The second one, insufficient oxygen supply, that means ischemic or hypoxia, acidosis, alkalosis, hypokalemia, symptom, this one, sympathetic and parasympathetic influences. So these all are the main factors. And the third one, they may also precipitated in patient receiving digitalis therapy. Then sometimes it may be occur due to the overstressing of myocardial contractible fibers. And fifth one, they may also provoked due to the presence of scarred or the disease tissues, especially in the myocardial infarctions. And sixth one is some antiarrhythmic drug may be themselves precipitate arrhythmias, especially like amiodarone, lignocaine, procaine, quinidine, etc., etc. In the same case, arrhythmia may be iatrogenic, and whereas underlying this the reason is unknown. Okay, now we can see the symptoms. Mainly it is a palpitation or fluttering sensation in the chest, skipping of heartbeat, and difficulty in breathing due to the poor oxygen supply and chest pain. The patient also experiences dizziness and may be faint due to the poor blood supply in the brain. Okay, these are the symptoms of this one. Now we can go for the classification. So classifications, it is a class 1, class 2, class 3, 4, class 4, like that. In the class 1, it is sodium channel blockers. So they have membrane stabilizing or anesthetic effect on the cell myocardium. Hence, this is class 1, that means class 1A, class 1B and class 1C drugs are used in this sodium channel blockers or class 1. So what are the class 1 class 1A? That mainly it is used to sodium channel and slow the phase zero depolarization. The basic mechanism of this one is the class A1 blocks the sodium channel and slow the phase zero polarization. Example, quinidine, procainamide, disopyramide. They suppress the AV node conduction and prolong the PR and QRS and QT. You know all what is this PR and QRS? These are the electrocardiogram signals. Okay, and potential duration. Okay, now we can go for the what are the important structure comes under this one. So quinine, so quinidine. So you know what is the difference between quinine and quinidine. Quinine and quinidine is a simple difference. This is the CGO specificity. This OH will be here in this position. That is called quinine. So this is the quinidine sulfate, procainamide, disopyramide, and these all are the class 1A. Now we can go for the class 1B. So these drugs are affecting the sodium channel in the both activated status, but they shorten the phase zero polarization, repolarization. Example, lidocaine, maxletin, and tocaine. So this is a structure of lidocaine. This is a maxletin. Okay. Now we come for the next one is a tocinidine and a phenytoin. This phenytoin structure you are well aware about this structure. You already synthesized in your laboratory and also it is so easy for you. Is a hydrogen derivatives. The next one is the tocinidine derivative. This one. Okay. Now we can see the class 1C. So what is the class 1C anti-arrhythmic drugs? So that is block the sodium channel with marked showing of phase zero depolarization. They markedly delay the conduction, prolong the P and R broaden QRS complex, but have variable effect on the action potential duration. Example is flecainidine and propofol and lorcainidine. So these are the this is the structure of flecainidine. This is a propofol and it is a lorcainidine. Okay, these are the important. This drug is lorcainidine is a very important drug. Now we can go for the class 2. Because class 1, class 2, class 3, class 4, these all are the important drugs comes under antiarrhythmia. So class 1 mainly it is blocking the repolarization. Okay, so next one is a class 2, there is a beta blockers. So already we have discussed about alpha blocker, beta blocker and both alpha beta blocker in the previous studies like antihypertensive. So here it is a class 2 beta blocker. It is included the beta adrenoreceptor blocking drugs that is decrease the myocardial response to the ephedrine and non-epinephrine because of their ability to block beta block receptor of heart. So example for this one is the propranolol, esmolol, acebutolol, and sotalol and timolol. This is the structure of propranolol. We have discussed about this propranolol. These are the esmolol, acebutolol, sotalol, and timolol. So these all are the drugs comes under class 2 drugs. Now class 3. So mainly it is a first what was so to see the sequence of this one, class 1 is the sodium channel blockers. That is the class 1 A, 1A, 1B, 1C. Then we have seen class 2 that is the beta blocking agents. Now class 3 it is the potassium channel blockers. So that is very important. Sometimes they may ask questions. Explain the chemistry of potassium channel blockers. That time you don't know like that you cannot say. So this is the potassium channel blockers. So sodium channel blockers already we have studied in the first classification. Sodium channel blockers, like procainamide, like that. Okay. So that may be asked like that also. So this class of drugs prolongs the repolarization, prolongs the refractory period, and increase the ventricular fibrillation threshold. So these drugs are in the general potassium channel blocking agent like beryllium and amiodarone. This is the amiodarone and beryllium. This is the next one is the class 4 drugs. That's the class 4 drugs are. It is a calcium channel blockers. So calcium channel blockers really we have seen it is a verapamil, diltiazem, and 1,4-dihydropyridine derivatives like felodipine, familodipine like that. So these all are the class of drugs which is used in the calcium channel blockers. So what it is acting? They are acting by inhibiting the movement of calcium through the channel across the myocardial cell membrane and vascular smooth muscle by reducing calcium flow, conducting through synovial artery, SA node and AV node is slowed and the refractory period is prolonged, resulting in the suppression of arrhythmia. So these are the example of calcium 4 channel calcium channel blockers like verapamil and diltiazem. Now we can see miscellaneous drugs like adenosine, digoxin. Okay, now we can go for the detailed chemistry of class 1 or sodium channel blockers. So mechanism of action of this one is this agent block the specific channel that is decrease the threshold of excitability, and also it is decrease the conduction velocity in fast response tissue and decrease the QRS duration, and also it is inhibit the triggered activity arising from the delayed after depolarization, simply we can call it DAD, or early after depolarization, and shift the voltage dependence of recovery from inactivation to more negative potentials. So these are the possible mechanism of action of class 1 drugs. So this is a quinidine. Quinidine, it is a prototype of main prototype of antiarrhythmic drugs. It is a chemically alkaloids obtained from the cinchona bark. So it is a diisomer of quinine. So quinine, is the use of the antimalarial drugs. So what is the basic difference between quinine and quinidine? This OH only. This residual specificity only the difference between quinine and quinidine. OH നമ്മൾ ഇവിടെ ഇടുകയാണെങ്കിൽ നമ്മൾ ക്യൂനിൻ എന്നും ഈ ഭാഗത്തിലാണ് അതിനെ ക്യൂനിൻ എന്ന് വായിക്കാം. Okay. It is a quinolate nucleus. Okay. So the properties are white and almost white crystalline powder, insoluble in acetone, and soluble in water, soluble in boiling water, alcohol, etc., etc. So pharmacokinetics and quinidine is available in the salt form. This and all, and the plasma protein binding about 80 to 90% bind to the plasma protein. Okay, therapeutic use. Quinidine is a long-term use for treatment of ventricular premature depolarization or the prevent recurrence of ventricular tachycardia after cardio version of the arrhythmia. Then next one is the procainamide. This is amide derivative of local anesthesia. Okay, procaine. It is a showed a similar mechanism, pharmacological effect, and the therapeutic efficiency of quinine with the following differences in the pharmacokinetic and pharmacodynamic activities. It's a less potent and a mammalian antivagal action, and it decreases the conductibility and AV conduction to lesser extent. It also does not block alpha blocker alpha receptor blocking agent, hence fall the BP in minimal, and it is mainly because of ganglionic blockade. This is the structure of our procainamide. Okay. Mainly it is a pharmaco. This one is it is a metabolism. It is metabolized the first pass. It is undergo the first pass metabolism and raised active metabolic again as still procainamide. That is active metabolic. This lacks sodium channel blocking activity, but blocks the potassium channel, and 50% of administered the excreted urine unchanged in the urine. Okay. This is the diisopyramide. In നമ്മുടെ സിലബസിൽ നമുക്ക് സിന്തസിസ് ഉള്ളതാണ്. ബാക്കി അങ്ങനെ സിന്തസിസ് ഇല്ല. ഡൈസോപെറമൈഡിന് മാത്രമേ നമുക്ക് സിന്തസിസ് ഉള്ളൂ. This drug shows the similar cardiac electrophysiology activity as well as the quinidine and procainamide. Hence, it is used as a substitute for the above two drugs. In the preventing the recurrence of ventricular tachycardia and ventricular fibrillation. The structure of this drug. Okay. The synthetic part. Step 1, preparation. So it is a phenyl acetonitrate treated with 2-bromopyridine in presence of soda made. So it is a formation of 2-phenyl pyridine 2-phenyl acetonitrate. Okay, then the step 2, it is a 2-phenyl 2-acetonitrate is treated with uh, N2-chloroethyl N-isopropyl propane 2-amine in presence of soda amide. So it is formation of 4 diisopropylamino, 2-phenyl, 2 pyridine butanitrate. Third step is the same obtained product is treated with acidic condition, so it is formed disopyramide. Then we have to treat it with a phosphoric acid, so we are getting disopyramide phosphate. So this is the synthetic protocol for disopyramide phosphate. Pharmacokinetic is oral. We are used intravenous route also administration. Undergoes the metabolism in liver through the N-aldealkylation reaction. About 80% of drug is excreted in unchanged in urine. Okay, so these are the adverse effect. Therapeutic use, it is used as the antiarrhythmic agent to suppress the treat sustained ventricular or the supraventricular arrhythmias. Dose is 450 or 150 for the 4 times per day. Lidocaine. Lidocaine is the drug of choice for the treatment of ventricular urticaria. Moreover, it is commonly employed in local anesthesia. So this is the structure of this one, lidocaine. Pharmacokinetic, it is a completely metabolized liver by hydrolysis. Deethylation and conjugation reaction also may happen, and these all are the important adverse reactions. Therapeutic use is treatment of arrhythmias. Okay, and another one is a mexiletine. It is the local anesthetic drug. It is also possesses the active antiarrhythmic activity. It shows the chemical and pharmacological resemblance of to lidocaine. The only difference is the that is does not undergo the phosphorus metabolism to the extent of lidocaine. Hence, unlike the matter, can administer oral route. Because this is the structure of mexiletine. The pharmacokinetics mainly it is undergo the liver metabolism of the liver through CYP-D6 and CYP-1A2, and primarily it is 10% of drug is excreted and used in the kidney. Okay. Therapeutic use is treatment of arrhythmia and also employed in the patient who have unresponsive to lidocaine. It is a use of treatment of ventricular arrhythmia, tachycardia followed by myocardial infarctions. Okay. And it is a tocainamide. Tocainidine is the hydrochloride for primary amine along with the lidocaine exhibiting the class 1B antiarrhythmic property. The tocainide hydrochloride stabilize the neuron membrane by reversibly binding to the and blocking open the inactivation of voltage gated sodium channels. They inhibit the inward sodium current requirement for initiation and conduction of impulses that reduce the excitability of myocardial cells. This is the structure of the drug, lidocaine, ticoinidine. Our important drug is a phenytoin. Phenytoin is a hydrogen derivatives. You know it is we are used for anti-epileptic drugs. Okay, so it is also having epileptics and anticonvulsant drugs. So mainly, so phenytoin is promote the efflux from the neurons located in the motor and cortex, thereby stabilizing the neuron and inhibiting synaptic transmission. Okay. So mainly it is used for the control of seizures. So that's why we are calling it anticonvulsant and or anti-epileptics. It is work to reduce the spread of seizure activity in the brain. Lorcainide. Lorcainide is class 1C antiarrhythmic agent that is used to help the restore normal heart rhythm and conduction in the patient with premature ventricular contractions, ventricular tachycardia, and Wolff-Parkinson's White syndrome. Okay, so it is a lorcainide. Now we can go for the class 2, that is a beta blocking agent. So beta blocking agent already we know, right, we have studied very classification also, we have seen beta blockers. Okay, these are the drugs for beta adrenergic blocking agent that present on the nodal cells like SA and SV node, thereby suppressing the rate of ectopic pacemaker activity mediated by the sympathetic stimulation. In other hand, these drugs control the arrhythmia provoked by sympathetic stimulation or by circulation of catecholamines. These drugs are considered to be the more safer than any other class of arrhythmic drugs. Beta blockers used in the arrhythmias, including propranolol, esmolol, satilol, and acebutolol. Satilol is a non-selective beta blocking with addition potassium channel blocking activity. It is different from the propranolol in the following aspect. It has no membrane stabilizing effect. It is increased the ER of cardiac tissues. It is enhanced the duration of monophasic action potential in the both atria and ventricular in the dose dependent manner, and it does not increase the heart rate, isolated heart tissue. It is prolong the QT intervals. So this is the structure of this one. Now we can go for the potassium channel blocking. So here we have discussed sodium channel blockers, beta blockers, and now it is a potassium channel blockers. Potassium channel blockers mainly it is acting as a prolongation effect of mostly due to the blockade of potassium channel through enhance the inward sodium current produce that QT prolongation. The cardiac block of potassium channel increase the action potential duration and reduce the normal automaticity. So this amiodarone. Amiodarone is the most preferred broad-spectrum antiarrhythmic drugs used for the dreadful ventricular arrhythmia. It is showed structural resemblance with thyroid hormone owing to the presence of iodine and its structure. Like thyroid hormone, it is also possesses affinity towards the nuclear thyroid receptor, thyroid hormone receptor. Pharmacokinetics, it's a 30% bioavailability, so it is a highly lipophilic drugs get accumulated in the muscle in the fat. It is metabolized in the liver, yield active metabolites. Does ethimoridone, that is exert similar action of the parent drug, so it is eliminated primarily and hepatic metabolism by biliary excretion. A small amount of does ethylaminoderone, it is found in the urine. Okay, that's all about as per your syllabus. Only this much only we have to study. Hope you understand the thing. So if you have any doubt, just call me. Thank you very much.